Okay. Good evening, everyone. Today's class is on evaluation of optic nerve head, and it will be moderated by Rathini, Lilian, David, ma'am. So we will be covering the anatomy of optic nerve head, clinical examination of optic nerve head, glaucomatous optic neuropathy, and the imaging modalities. Introduction. Optic nerve head assessment is crucial for early glaucoma diagnosis. We can diagnose glaucoma often before the visual field defects appear. Regular ONH evaluation also keeps help track of disease progression and treatment efficacy. ONH characteristic assist in determining the risk of glaucoma development in suspected cases also. Now the anatomy of optic nerve head, it has four parts: the surface nerve fiber layer, the pre-laminar layer, the laminar layer of containing the lamina cribrosa, and the retrolaminar layer. Now the ONH is formed by the ganglion cell axons converging from the retina. The physiological cup of the ONH is formed from the central depression where the vessels emerge and represent partial or complete axonal absence. Glaucomatous cupping is enlargement of central cup in optic nerve head caused by progressive nerve fiber loss and progressive thinning of the neuroretinal rim. Here you can see the normal physiological cup and progressive deepening of the cup in a glaucoma. Now, axons in optic nerve are arranged in distinct pattern. The peripheral retinal fibers or axons are located in the peripheral portion of the optic nerve, whereas the central area of the nerve contains fibers from the posterior or central part of retina. The macular fiber from the papillomacular bundle and enter the disc temporally. Here. The susceptibility for NRL loss is higher in regions with long distance to the exit of central retinal vessel trunk than sectors with short distance. That is, the fibers in periphery are affected first.
1 minute. Jay, can one of the first years explain that diagram? The arrangement of ONH in the optic nerve head? The maculopapular bundle, yeah. They go to the of the optic nerve head. And what about what goes to the superior and the inferior part of the optic nerve head? The arcuate fibers. Yeah, tell me, Shamika, you tell.
Respectively occupy the upper portion and the lower portion of the optic disc, and the nasal fibers enter
nasally. So which is most prone for glaucomatous damage? Which are more susceptible? The arcuate fibers, okay, which come from the peripheral retina are more susceptible for glaucomatous damage. Okay, the last to go is the papillomacular bundle. Okay. Go on.
Pathogenesis of ONH changes in glaucoma are due to mechanical effect. Due to raised IOP forces the lamina cribrosa backwards and squeezes nerve fibers within, disturbing the axonoplasmic flow. Vascular changes include ischemic atrophy of the optic nerve. Oxidative damage is due to glutathione present to protect against the hydrogen peroxide damage. This is still under research. Now the examination techniques involve qualitative and quantitative methods. Qualitative involve slit lamp indirect ophthalmoscopy, direct ophthalmoscopy, disc photograph, red-free fundus photograph, simultaneous stereo disc photography. Quantitative involve optical coherence tomography, laser polarimetry, confocal scanning laser ophthalmoscopy, disc photography with digitalization, stereo disc photography with optic nerve analysis. Now, moving on to slit lamp biomicroscopy. With the help of 60D, 78D and 90D lenses, the technique involves illuminating beam and eyepiece are kept coaxial to focus on the cornea. Then we localize the red reflex through the pupil, and then lens is placed in front of the eye, and then we pull back the slit lamp from forwardmost position until the retina is seen. And upon seeing the retina, we can follow the vascular arcades to visualize the disc. Now, how to measure disc size clinically? Now, the height of the slit beam is decreased to coincide with the disc margins of the NRR in the superior and the inferior, and then we can measure the size by the graticule, and then it is multiplied by the correction factor of the lens to get the actual disc diameter. So for example, if we are getting disc diameter as 1 mm by the graticule, then we have to multiply by the correction factor of the lens to get the actual disc diameter.
1 minute. Fellows, why do you need to multiply by the correction factor when you use those high power convex lenses? to magnify it. Yeah.
Now, how to measure disc size by direct ophthalmoscopy? This was a technique described by Gross. The 5-degree aperture of the Welch-Allen ophthalmoscope projects a circular spot close to the optic disc, and the size of the disc is compared with the circle that is projected onto the retina. Now, the area of the disc can be calculated by the formula.
What is the diameter of the 5-degree aperture? Yeah, 1.5 mm. So that when it's projected, it's more or less equal to the average size of the disc. Okay. So although we don't use why don't we use direct ophthalmoscopy for evaluation? What? Yeah, it's not stereoscopic. Yeah. Okay.
So the area of the disc can be calculated by the formula pi by 4 into horizontal diameter and the vertical diameter. So for example, if we are getting horizontal vertical diameters as 2 mm, then the area will be 3.14 mm. Now the parts of optic disc. The optic disc contains the optic cup in the central, which is the depression, and beyond the cup is the neuroretinal rim till the edge of the optic disc.
You want me to go back? No. First is, do you understand that picture? So which is the neuroretinal rim?
At the periphery is the neuroretinal rim.
How do you define it?
Ma'am, the nerves passing.
What is? It's the area. Okay. So in simple terms, from this thing, what is the
area between the edge of the cup
Ah.
till the edge of the optic disc?
yes. So in simple words, that's what it means. Point it out on that.
Yeah. The edge of the cup and the edge of the disc. This.
Yeah. Like you were saying, to ascertain, you have to look at where the vessels are kinking to make out where exactly the rim begins.
Now moving on to the 5 hours of clinical disc assessment. First we observe the scleral ring to identify the limits of the optic disc and its size. Then we identify the size of the neuroretinal rim, and after that we examine the retinal nerve fiber layer and look for the region of peripapillary atrophy. And in the end we'll look for retinal and optic disc hemorrhages. We'll be explaining in detail one by one. Now firstly the L-shaped scleral ring. It is the normal anatomical variation seen as a thin white ring adjacent to the optic disc margin, this one. It represents the scleral opening that surrounds the outer border of the optic disc. Basically, it represents the disc margins.
So when you're measuring the disc size, you will measure just inside the scleral ring. Okay.
Now the disc size parameters. Average disc size is 2.82 plus minus 2.52 mm as reported in the Chennai glaucoma study. However, the disc size area can vary from 0.8 to 0.6 millimeter square. It varies with race. It is smaller in whites and larger in blacks, and varies with axial length and refractive error of the patient also. Myopes usually have larger disc, whereas hyperopes have smaller disc. There is no variation with age after 10 years, and there is no variation with BCVA, anterior chamber depth, body height and gender. Now these are various mean optic disc area as described in various studies. Chennai Central Eye India study had 2.2 plus minus 0.5 mm, and Vellore Eye study had 2.58 mm square. Now defining microdisc and macrodisc. Microdisc are plus 2 standard deviation increase from the normal. They have larger neuroretinal rim and less crowding per square millimeter of the disc area. They have higher count of nerve fibers and total area of lamina cribrosa pores. Examples are optic nerve pit and morning glory syndrome. Now microdisc are minus 2 standard deviation from the normal. Optic nerve fibers are crowded, suggestive of deformed lamina cribrosa and susceptible to high damage by high IOP. Less optic nerve fibers are so they have less reserve capacity and are more prone for glaucomatous nerve damage. Examples are non-atretic anterior ischemic optic neuropathy, pseudopapillodema, and optic nerve head drusen. This is a microdisc and this is a microdisc. Now disc size, the average disc size is between 1.63 to 2.43 millimeter square. Macrodisc can be defined as more than 2.43 millimeter square, and microdisc can be defined as less than 1.63 millimeter square. Now here is the average disk size. This is a macro disk and this is a micro disk.
So 1 minute. So disk size anything less than 1.5 you can consider it as a small disk. Okay, more than about 1.5 to 2.2 to 2.4 it can be average, and more than that it is a large disk. So it's very important to ascertain the size of the disk. Okay, because a large disk may have a, what did he say in the previous thing? A large disk can have a large cup which may not be pathological. Okay, and a small disk can have a small cup, in spite of that it can be pathological.
Moving on to the disk shape. The disk shape is vertical or oval, with vertical diameter being the maximum diameter and the horizontal being the minimum diameter. It is not essential for diagnosis and pathogenesis of glaucoma. However, it influences the distance between the neuroretinal rim and the vascular bundle, the central retinal vascular trunk.
So first is, do you understand that? So the normal shape of a disc is, it's vertically oval, okay, and the shape of the cup is, in normals, it's mostly horizontally oval. But in glaucoma, what happens? Yeah, because of the loss of the neuroretinal rim, especially in the poles, the cup tends to elongate vertically. Okay.
Now the correlations for disc shape. There are no correlations with age, sex, body weight or height. However, refractive errors affect the disc shape, leading to an oval, oblique or elongated shape. Myopes with less than -8 diopters, there is not much difference in disc shape. However, myopes with more than -12 diopters, there can be increase in ovality of disc due to stretching. Shape variations are also seen in myopes, astigmatism, amblyopia and congenital anomalies. The isn't rule may not be applicable when the disc is not vertically oval. Now, torted versus tilted disc shape. Optic disc is torted is when vertical axis of the optic disc is rotated more than 15 degrees from the vertical meridian. However, it is tilted optic disc is called when the three-dimensional angulation of the anterior-posterior optic curve is there. Now here is the are examples of tilted disc. Now the first one image you can see is a normal disc without any tilt. Now the second image, it is tilted nasally. This third image is tilted vertically upwards, and the last image is tilted obliquely. Here are more examples of myopic tilted disc. Moving on to the neuroretinal rim. Neuroretinal rim is the intrapapillary equivalent of retinal nerve fibers and the optic nerve fibers. It is most important parameter for disc evaluation. Mean neuroretinal rim area is 2.29 plus minus 0.3 millimeter square as reported by the Chennai glaucoma study. The rim area and disc area have a strong positive correlation. That means a larger disc has a larger rim, and every 1 millimeter area increase in disc area leads to 0.5 increase millimeter area in of rim. Higher nerve fiber count and more portion lamina cribrosa. Now, as you can see, this is the neuroretinal rim. This is the inferior, temporal, superior and nasal part. We'll be discussing more in the next slide. Now, this is the neuroretinal rim area as reported by various studies in India. Least was reported by the Vellore eye study with a rim area of 1.6 mm and most by Andhra Pradesh eye disease study with an area of 2.8 mm. Now, the Isle room was first described by Werner. The optic disc is vertically oval and the cup is horizontally oval, giving the rim a typical configuration of inferior thickest followed by superior, followed by nasal and temporal. This IST rule is obeyed in up to 71% of total population, and including the nasal rim it is obeyed in 45% of the population. However, this isn't rule is not followed in glaucomatous changes. The sequence of loss is usually first.
1 minute, Jay. So, do you understand what he's trying to say? The neuroretinal rim, in most people, the inferior rim is thicker than the superior, and then the nasal, and then temporal. In almost all people, you will have the temporal rim to be the thinnest rim. Okay, but it's found that only about 50% go by the rule. Okay, and but if you take out the n from the equation, then about 71% obey this rule. Okay. So, but in glaucoma, the reverse happens. The thinning is most often seen in the inferior rim, then superior, nasal, and temporal. Okay. And why is the poles most prone for glaucomatous damage? Second is? Now, laminar pores are larger and thinner. There's less of interpore connective tissue. And what is the other theory for the rims to be lost in the poles? Something to do with the retinal vessels. The poles which is farthest from the exit of the central retinal vessels are lost earlier. Okay, maybe because of lack of stabilization. Okay, and also the axons, that is the nerve fibers, are much thicker. That which comes to the poles are thicker. Okay, go on.
The sequence of loss is usually first in the inferotemporal and the superior temporal region of the disc. Why is that? Because these areas have the widest retinal arterioles, largest laminar pores, and densest RNFL. Also the distribution of thickest nerve fibers in the inferior and superior part are more glaucoma sensitive. Now, what happens to NRR as the glaucoma progresses? Gradually, the NRR is lost in all sectors depending on the stage of the disease. In early glaucoma, the loss is predominantly in the inferotemporal and superiotemporal region. In moderately advanced glaucoma, the temporal rim is lost most. However, in severe glaucoma, only rim remnants are remaining in the nasal sector. That too more in the upper nasal than in lower nasal sector.
1 minute, Jay. So when you're talking about the disc, you must defocus from the cup. Okay, you must focus on the neuroretinal rim. Okay, it's only because neuroretinal rim is lost that your cup is enlarging. Huh?
Okay, now describing the notching. While evaluating the NRR, the contour is more important than the color. The focal atrophy of neural retinal rim often begins as a small and discrete defect. This notching can be defined as focal or polar defect or a pit-like change in the NRR. It usually occupies a space of less than 2 clock hours. Like you can see, this is an inferior notch and this is a superior notch. The rim and disc ratio at the area of notch is lesser than the area immediately adjacent to the notch. However, a complete loss of NRR tissue in an area is defined as a loss or excavation. Now, there is examples of NRR. The first image shows thinning of NRR superiorly. The second image is showing complete loss of tissue inferiorly, which is called as excavation or a loss. There are some examples of sloping rims. This is an inferior slope, a superior slope, and temporal slopes.
You just see the rim sloping. So that doesn't mean the rim is lost there. Okay, the rim is just sloping that way. So you have different types of slopes. So the first one is showing an inferior slope. The second one, both the superior and the inferior rim is sloping. And then the last two are showing temporally sloping rims.
Now, color of NRR. NRR is usually orange pinkish in color. Increasing pallor is a typical sign of optic nerve damage. Pallor means yellowing. Non-glaucomatous optic nerve damage. It is seen more in non-glaucomatous optic nerve damage than glaucomatous optic nerve damage. Here we can see that there is a deeper cup, but the color of NRR is maintained. Pallor is less. Here we can see the cup is okay, but the pallor is more.
So in non-glaucomatous nerve damage, you will not have an increase in the cupping. But however, in some situations, you will still have. Anyone want any of the fellows? Where will you have increase in cupping with pallor? Any neurological condition?
AAON can.
Yeah, AAON, and then anything else? Even tumors, supracellular, intracellular tumors. Okay, go on.
Here are examples of pale disc and a pale and cup disc. First image is the cup is okay, but the disc is pale. The second image, you can see there is a deep cup and with a pale disc.
The left image, can you see the temporal pallor? And the right one shows the completely pale and cupped disc.
Now moving on to the cup disc ratio. Optic curve, as discussed earlier, is the excavation seen in the optic nerve head. The cup disc ratio is the ratio of vertical cup diameter upon the vertical disc diameter. Now, depending on the size of optic disc, we can a large disc has a large cup with a healthy NRR, and a myopic eyes have shallow cup. Now, the cup margins can be assessed by the location of kinking of the vessels here. Now, according to Chennai glaucoma study, the average vertical cup disc ratio is 0.36 and average horizontal cup disc ratio is 0.39. Now, what are the types of cupping? According to Chennai glaucoma study, there are 4 types of cupping: a disc with no cup, a disc with well demarcated cup, a disc with partly sloping rims, and a disc with fully sloping temporal rims. Now, variations in cup disc ratio. In the first image, you can see the cup disc ratio is 0.1 because the cup is quite small. In the second image, you can see the cup is 0.32 is cup disc ratio is 0.3 to 1. In the third image, you can see that cup is almost the half of disc diameter, so it is 0.5. Moving on, it is 0.7, and in the second last image, you can see that the cup is quite broad, is 0.8. It is also a large disc, and in lastly, you can see a cup disc ratio of 0.9 to 1. Now, parameters affecting this cup disc ratio. There is no correlation with age, refractive error, gender, and axial length and depth of anterior chamber. In cases with cup disc ratio discrepancy, disc size should be compared to determine the true discrepancy. Now, in glaucoma, the cup deepens according to type and the intraocular pressure. Deep cup is seen in juvenile open angle glaucoma and secondary open angle glaucoma. This is the first image. You can see the cup is very deep. And in shallow cups are seen in primary open angle glaucoma and myopic type of primary open angle glaucoma. Here. Moving on to the RNFL defect, retinal nerve fiber layer defect. Healthy RNFL is a alternate striation of a dark and white band, as you can see in the first image. It is better visualized in a red-free filter image. You can see alternating dark and light striations beyond the disc margin. Now, RNFL defect is defined as thinning or loss of peripapillary retinal nerve fiber layer. It is a very strong indicator of glaucoma, but it is not pathognomic. Most localized RNFL defects are associated with neuroretinal rim thinning, notching, or vertical cup enlargement. It is more common in temporal inferior sector, followed by temporal superior sector. It is best viewed with the red-free filter, and it is more common in normotangential glaucoma than primary open angle and more than secondary open angle. Now, the pattern of RNFL defects are, there are 3 types of defects. Slit defects, which are narrow dark streaks from the superior temporal or inferior temporal poles seen on red-free light. They are highly specific for glaucoma and may precede disc and field changes. Wedge defects are fan-shaped loss in superior temporal or inferior temporal arcuate regions, often seen with rim notching and matching visual field losses. Diffuse defects are most common. They are generalized RNFL thinning, often hard to detect due to low contrast. First image shows the slit defect. You can see.
Make out the slit defects there? Those dark areas.
Yeah. It is better visualized on the red-free filter, where you can see the alternate bands are lost, and this is a full dark line is there.
And when there's an RNFL defect, you'll be able to see the retinal vessels also better, because they're usually embedded in the retinal nerve fiber layer. When it is lost, you see them much brighter. Go on.
Now, moving on to the wedge defects. Wedge defects are fan-shaped defects seen on the superior temporal more commonly. Here you can see this is a complete dark band extending from the disc margin. This is a red-free filter image. Now, moving on to diffuse defects. It is better visualized in the red-free filter, where you can see the whole area is there's loss of light and dark striation. It looks homogeneously dark.
Although diffuse defects are common, it's not very easily made out because it's difficult to see the contrast. Okay. And with aging and a lightly pigmented fundus and all, it's difficult to make out RNFL defects.
Moving on to some vascular defects. This is bayoneting. Bayoneting is double angulation of blood vessel. You can see here, this is the first kink and the second kink follows an S kind of shape. This is seen when retinal vessel cross the sharpened rim and then they bend sharply at the edge of the disc. Now, nasalization of vessels. As the cupping increases in glaucoma, the blood vessels appear to shift nasally due to loss of neuroretinal rim. Here you can see that they have become nasally oriented. Vascular loops are congenital vascular anomaly. They are elevated coiled cluster of blood vessels around the disc extending into the vitreous.
This is not congenital. This is in glaucoma. Why do you have vascular loops? Why do you have the vascular loops in glaucoma? Usually you find them in advanced glaucoma because of ischemia or the vein occlusions.
Bearing of circumnilian vessels. Normally, the vessels rest on the neuroretinal rim. However, due to loss of adjacent rim, the vessel appears suspended below the NRR. That is in the cup.
Anybody wants to guess? So before it becomes like a circumlinear vessel, it just bridges across straight across to the rim over the cup, and then it collapses and curves like that. So it is a stage which occurs prior to the BCLV once the rim recedes.
Moving on to disc hemorrhages, also known as Drans hemorrhages. They are splinter or flame shaped or blot hemorrhages near the disc margin, usually seen in superior temporal or inferior temporal. They are more common in inferior temporal sector. They are more commonly seen in normotangential glaucoma than primary open angle glaucoma, and they can precede RNFL loss, launching, or visual field defects, and they often signal progression of the disease. They are transient, not lasting more than 35 weeks, and better seen on red-free filter. But they are not specific to glaucoma. They can also be seen in hypertension, diabetes, NAION, and papillitis.
So on an average, they last for about 8 to 12 weeks. Okay, but you also have to keep in mind other conditions in which you will find a disc hemorrhage. Okay. Another reason which is not mentioned is a posterior vitreous detachment. In that also you can have a disc hemorrhage.
You can see a disc hemorrhage in the inferior temporal quadrant. They often have feathered edges and a radial orientation. Here there is a very faint, in the second image there is very faint disc hemorrhage inferior temporal area. Now the ocular hypertension treatment study. The aim of the study was to determine whether optic disc hemorrhages can predict the development of primary open angle glaucoma in the ocular hypertension study group. The results were that disc hemorrhages increase the risk of developing POAG by 6-fold in univariate analysis and 3.7-fold in multivariate analysis. And the cumulative incidence of POAG in eyes without optic disc hemorrhage was 5.2 compared to 13.6 in eyes with optic disc hemorrhages, having a higher incidence. And the study concluded that occurrence of optic disc hemorrhages was associated with increased risk of developing primary open angle glaucoma.
Disc hemorrhage, you have to really look for it to identify it. Many times it is missed. Okay, so that's why they say disc photographs are really helpful for identification of disc hemorrhages. Okay, and sometimes there's a resolving hemorrhage which you can easily miss if you don't examine in detail.
Now moving on to peripapillary atrophy. It has two regions, the alpha zone and the beta zone. The alpha zone is the outer region of peripapillary atrophy. It represents irregular RPE or retinal pigment epithelium pigmentation, as you can see here. It is most common in temporal quadrant, but it can be seen in normal eyes as well. The beta zone is the inner zone of peripapillary atrophy with visible sclera and the choroid. It is more distinct, and the presence of beta zone should raise the suspicion of glaucoma. In the second image, you can see alternating RPE pigmentation in the alpha zone and the beta zone where you can see the bare choroid and the sclera. Now moving on to disc asymmetry. Disc asymmetry between the two eyes can be because of variation in size of the cup between the two discs, the width of NRR, the vessel course, and due to the peripapillary atrophy. Asymmetry of more than 0.2 mm with symmetrical disc and no anisometry greatly increases the suspicion of glaucoma.
It means asymmetry of the cup disc ratio, okay, of 0.2. But for that, the disc sizes should be symmetrical. If one disc is larger than the other, then that may not have much value.
Now here are examples of disc asymmetry. You can see that the first image or the right eye is smaller than the left eye.
So the cup is looking larger in the left eye with a larger disc.
OCT image where you can see the difference in the disc area and the rim area, signifying that a larger disc has a larger rim area and the smaller disc has a smaller rim area. Now there is a question that why glaucoma tends to be overdiagnosed in a larger disc and underdiagnosed in a smaller disc. In larger microdiscs there is deep but physiological cup, but the NRR is healthy and other interpapillary variables like the RNFL and the peripapillary atrophy are normal or absent. In smaller optic discs, although they have no cup, early and moderate advanced glaucomatous nerve damage is overlooked because they don't have any cups, so there is masking. Moving on to the laminar dot sign. As loss of axons progressive, the normal color is replaced by the grayish hue. It suggests a deepening of cup in advanced disease. Moving on to glaucomatous versus non-glaucomatous optic nerve head changes. In glaucomatous optic nerve head changes, the visual acuity is affected very late. However, in non-glaucomatous, it is affected early. Color vision is affected more in non-glaucomatous nerve changes. The rim changes are seen in glaucomatous but not in non-glaucomatous. However, pallor can be seen. The cup to field mismatch is absent in glaucomatous changes. That means whatever the cup is, the fields will be matching. If there is any defect in the cup, the fields will be matching that. However, in non-glaucomatous optic nerve changes, they are present. That is, the cup does not correlate with the fields. The visual fields respect the horizontal meridian, and in non-glaucomatous, they respect the vertical meridian. RAPD is absent in glaucomatous nerve changes unless severe, and peripapillary changes are suggestive of glaucomatous changes but not in non-glaucomatous changes. Now moving on to some disc anomalies. Here you can see is a myelinated nerve fiber defect in the inferior sector. Here you can see is an optic disc coloboma. There is a complete loss of the neuroretinal rim and the development on the inferior temporal side. This is an image of morning glory syndrome. You can see a large disc with a peripapillary atrophy, and here is an image of disc drucens, which is also a large disc. Moving on to the questions.
Anybody wants to tell something about DDLS?
It comes
After the question.
yes, after this.
No, finish off the presentation, then we go to the questions.
Okay.
Finish off all this.
Now, moving on to the subtypes of glaucoma by optic nerve head changes. There are 5 types. High myopic disc pattern, focal normal pressure pattern, also known as focal ischemic pattern, age-related atrophic or senile sclerotic, juvenile open angle, and primary open angle. Now in high myopic disc pattern, you can see a large disc with a concentric and a shallow cup, thin superior rim and an inferior rim, no focal retinal nerve fiber defects, but there is marked PPA, as you can see, marked peripapillary atrophy. Normal to high IOP and dense focal visual field defects, where the superior defect is equivalent to inferior defect. The focal ischemic defect, there is normal size disc, but there is deep and steep cup with thin superior rim and inferior rim. Focal RNFL defects can be present, and there is frequent disc hemorrhages. PPA may or may not be present, but IOP may be in the range of normal to high, and there are dense focal visual field defects more in superior area than the inferior. Moving on to senile sclerotic type. The disc is normal in size. It is saucerized, meaning this sloping is present. Cup is shallow, concentric, and moth-eaten appearance. There is no focal RNFL defects. The fundus is tessellated in appearance, normal to high IOP, and relative defects, visual field defects with diffuse loss. Now moving on to juvenile open angle glaucoma. The disc is normal in size with a deep steep cup, and there is no focal RNFL defects, tessellated fundus with a normal to high IOP.
Many times you see a large disc with juvenile open angle glaucoma. Shown is also a large disc.
And what is the RNFL like? There are no focal defects, but what is there? Okay, what is absent? What should be there normally and it is absent? How does a normal RNFL look like? You saw earlier, right? What do you see? Huh?
Listening white.
White glistening stripes.
There's
Are
a
they there?
diffuse RNFL.
Huh? Yeah.
Diffuse
so then you should
RNFL
say no. So diffuse RNFL loss corresponds to the rim loss there, right? And is there what about the papillary changes? They're there or they're not? So you can see a
Temporal crease.
Yeah, you can see a beta zone, bit of alpha also.
Moving on to primary open angle, the disc can be normal sized with a diffuse round concentric symmetric cup. Disc hemorrhages and rim notch are rarely present. IOP is usually high and they can have diffuse visual field defects. This is a table summarizing the subtypes. Now the DDLS scale, that is damage likelihood scale, it is most widely accepted staging for glaucoma staging. It has 5 factors. It takes into account the CDR and the disc size also, reducing miscalculations in small or large discs. Focuses on the rim width and stages the glaucoma in a scale of 1 to 10 and monitors disease progression, which can be useful for tracking structural changes in glaucoma over time. And it can correlate with imaging also, like in OCT.
Who developed the DDLS staging? Fellows?
It is written there.
Space.
What is the advantage of the DDLS?
Standardized way of grading.
And takes
And
into
more
account
reproducible.
takes into account disc size and gives importance to the rim width to the disc ratio.
Here is a disc diagram. You can see that this is a disc with a vertical cup disc ratio of 0.5 to 0.6. There is an inferior notching, and you can see an inferior trans hemorrhage, a superior RNFLD defect without any peripapillary atrophy. This is how we document a disc diagram.
What is missing there? What should be there? One more thing.
Shape.
If you have a notch there, what else should be there? There should be another RNFLD inferior-temporally corresponding to that.
What else is missing? This size. You have to mention the disc size, whether it's small, average, or large. So detailed disc drawing recording is very important, okay, especially in the absence of photography and all. So it still holds good even today.
Moving on to the imaging, we are discussing disc stereo photography. For disc stereo photography, we use a Zeiss FF450 plus fundus camera. The photography includes taking one stereo pair of optic disc color in 20-degree field view in each eye and another photograph of 30-degree view using a red-free filter. This is a focus knob to adjust the field view. There is 50-degree, 30-degree and a 20-degree. Now the disc stereo photography involves using a screnoscope to view the stereo pairs of disc photography on a monitor. What it does is forms a single image by which you can assess the depth of the disc, and by adjusting the focus, there is fusion of both the images, giving a singular 3D stereoscopic view of both the images. Now, Planimetry is a software that we use to get the disc area, cup area, and vertical and horizontal disc diameters.
What is the difference between the type of photography with the size and this? What you're seeing here, which is the true stereo photography, is a pseudo stereo photography. True stereo is the pictures are taken at the same time, both of them using a what they call Allen separator. But in a pseudo stereo, you just adjust the focus 10-degree apart at a cross angulation and take it, so that you get a pseudo stereo view.
Now moving on to the questions. Can anyone describe what is the first step?
1 minute. So now can any of you quickly enlist what are the things that you should look for when you look at an optic nerve head?
Ma'am, we'll start with the 5 R's that were described. First R is the scleral rim. Then we'll see the neuroretinal rim, cup to disc ratio. Then we'll see the retinal nerve fiber layer loss, if there is any. Then the fourth one is the peripapillary atrophy. The fifth one is the retinal or disc hemorrhages.
Read the photograph.
Okay. Can anyone describe the disc?
Ma'am, the first point would be the ring
The size.
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 So first you say what is it? It's a color non-stereoscopic photo of the right or left?
Ma'am, it is the left.
The left eye. The disc is. Now start enumerating. Size. This size is average.
Ma'am, then the second point would be neuroretinal rim. So here we see that the rule is followed because inferiorly it is the most, then superiorly, then nasal,
Yeah,
then
so the
temporal.
neuroretinal rim is healthy. Then
Ma'am, the third point say retinal hemorrhages. If we have to see, there are no.
there are no.
Then ma'am, fourth is peripapillary atrophy.
Does this eye have peripapillary atrophy?
And mildly, I feel temporally there.
Temporally it is there.
And ma'am, fifth is retinal nerve fiber layer defect.
Retinal nerve fiber layer appears healthy. No defects, rather. Okay. Can anyone see a bearing there? There is an early bearing of the circumlinear vessel there. Okay, we go on to the next one. Next person. Come on.
Ma'am, the disc looks average size.
Previous one, sir.
So you go back to the previous one. So can we say that this has a nasalization of vessels? There are more blood vessels on the nasal side than the temporal. Can we say yes? No? Yes?
Yes, sir.
Yeah. So that bearing of circumlinear vessel also is kind of there. So based on that, can we say this is glaucomatous? So there is no obvious RNFL defect, even though we can't really comment because the quality is different. But rest of the things look normal. But there are some signs like the nasalization or bearing of blood vessel. So based on these things, and of course the cup disc ratio is slightly larger, maybe 0.6, 0.7. So can we say this is glaucomatous? How many of you would say glaucomatous? Raise your hands. Okay, no glaucoma. So 1, 2. So rest of them, what is the diagnosis? Is there anything else? So you should come up with the proper answer, right? But again, I want to reiterate that these nasalization, bearing of blood vessels and cup disc ratio are non-specific signs. You cannot pinpoint glaucoma based on that. Okay. Obviously, you need investigations, but this patient you would investigate. You will put it as suspect. But it would suffice to know that it looks more or less normal. Okay. If the visual fields is normal, you might want to brand this as a normal. Okay. You wanted to say something?
Yeah, no, I just wanted to say that even if the isn't rule is followed. The inferior rim is more than the superior. In early thinning, it will thin a little, but it will still remain thicker than the superior. So if you see progressively, if you see some thinning, it may still be thicker than the superior, but if it is progressively thinning, then it is glaucoma. So don't stick to the isn't rule that much.
Moving on to the next question.
Next person.
Ma'am, the size of optic disc, it looks like an average sized optic disc.
It's a color disc photograph of the right eye, left eye. Right eye, yes. This size?
Size, it looks average size, but
Hmm.
pale it looks.
Pale. No, it looks pink only.
Pink.
Then, next.
Ma'am, the neuroretinal
Hmm.
ring inferior,
Inferiorly, what are you saying?
when thinning is present inferiorly,
Is it thinning or some
and notch is
notch?
present.
Yeah, inferior. Infratemporal notch, you're saying, yes. Then,
Ma'am, peripapillary
cup to disc ratio is around
2.6.
0.6. Okay.
0.6.
Peripapillary atrophy.
Ma'am, it is present.
Then,
Ma'am, no hemorrhages are
Fast.
seen. No hemorrhages are seen.
okay, no vascular changes. Yes, okay. Then, nerve fiber layer defect. Is there anything? Look at where the notch is. Do you see something?
Inferotemporal.
Yeah, maybe because it's a tessellated fundus. It's not very clear, but there looks to be a inferior RNFL defect. Yes. So is this glaucoma?
Yes.
Yes.
Ma'am,
Yes. If so, you will want to follow up and treat this patient. Okay.
Ma'am, the size of the disc is average. A tilt is present. It is asymmetric. The margin is
Asymmetry? You're not comparing it, no? The shape.
yeah. Sir, isn't rule is also not followed. There is thinning, inferior, superior,
What is there? Inferiorly, there is a
notch.
yeah, there is a notch. Superiorly,
Superiorly
also there is an early notch. Yes. Then
Ma'am, peripapillary
peripapillary
atrophy
atrophy
is
is there.
present.
Yes.
Yes.
Then retinal nerve fiber layer defect.
Yes, ma'am.
Where?
Ma'am, supero.
Can you make it
is-
out there? That dark area. Which
Yes,
is like a
ma'am.
wedge. It's fanning out from the disc margin. Yeah. So that is a wedge defect.
Okay.
Inferiorly also there is seems to be like there is a diffuse NFLD. This is glaucoma.
Yes, ma'am.
Definitely glaucoma. No retinal hemorrhage. That is something also that you should mention. Next person.
This is an optic in the head of the right side,
Right or left?
left side, with a cup to disc ratio.
Size of the disc.
Size is around 0.6 to 0.7.
Disc size.
So,
It's
no,
small.
average size.
Average or large?
Large size disc.
It's a large disc. No.
Yes, ma'am.
Then,
Ma'am, cup disc ratio is
how's the rim?
ma'am, the rim, there is thinning of the rim.
Where?
Ma'am, superiorly there is thinning.
More or less all
Yeah,
there is thinning
360.
everywhere, no, in all
360,
quadrants. So
yeah.
what is that called? What do you use? What term you use for that?
Ma'am, loss of neuroretinal rim, ma'am.
Uniform thinning there is,
Yes,
no?
yes,
Huh.
thinning, yes, ma'am. And
Yes.
the cup disc ratio is around 0.6 to 0.7, ma'am.
No, it's much more than that, no?
Yes, ma'am.
2.8 at
0.8.
least. What are the vascular changes you're seeing?
Ma'am, nasalization of the vessels
Hmm.
and ma'am, peripapillary atrophy may be seen in all gonads, and then the vessels are looping towards the center.
Bayoneting is there.
They are in the and
Can't
no
make out
hem-
the NFL too
Yes,
well in
ma'am.
this
Yes,
picture.
ma'am.
Laminar dots, are you able to appreciate? You're able to see the pores, the
Yes, ma'am.
lamina pores.
Yes, ma'am.
Hmm.
Lambda pole.
Okay, next person.
Ma'am, this is a optic disc picture of the left optic disc.
Left or right?
Right, ma'am. The right optic disc, ma'am, and it's a large disc,
Ball is average, yeah, okay.
average shaped disc, um, with neuroretinal rim thinning seen in the inferior quadrant, and there is notching in the inferior quadrant. The cup disc ratio is around 0.8, and there is no peripapillary atrophy, no disc hemorrhage is seen, and there is nasalization of the vessels.
Right side, you are seeing another picture, no? From there, you can also deduce something else. What is it? What picture is that?
Red free filter.
Yeah.
Can you make out? Wedge shaped defect.
Inferior
Can
defect.
someone point it out?
Point it out.
So whenever you see a rim thinning or a notching in that area, you should always look for an RNFL defect and see whether it is slit or wedge shaped, what kind of a defect it is, and immediately look at the opposite side for the RNFL defect. Because even though the rim may look normal, you may start having some RNFL defect there in the initial period. Okay, sometimes those defects may be little away from the disc also, rarely. So you should always look for both the poles. That's where the RNFL defects start. Okay.
Yes, sir.
Next question.
Next person. Quickly.
Ma'am, this is a normal size disc of the left eye with a cup disc ratio of 0.7 and nasalization of the vessels. There is sloping, no, not sloping, inferior sloping, and in the red free filter we can see an inferotemporal wedge defect, wedge shaped RNFL loss, and inferiorly there is in the red free there is an inferior disc hemorrhage.
So disc hemorrhages are also better appreciated on the
Red free
red
filter.
free. So you see there's a resolving disc hemorrhage there. So disc hemorrhages are usually fall after some time. You will find an RNFL defect in the place of the where there was a disc hemorrhage. So it means that the glaucoma, the process is ongoing. Okay. PPA.
There's a
Yeah,
temporal
red free.
recent and better appreciated.
Next. So this is glaucoma or not?
Yes, ma'am. This.
Yeah.
Ma'am, this is a disc of, there are two pictures of the left-sided disc. The left-sided picture shows, the color photograph shows a large disc with the cup disc ratio of about 0.7, and there is an anomalous looping of the vessels seen. There is an inferotemporal slit-shaped wedge defect.
What is slit-shaped wedge defect? It's a wedge defect. And how does the rim? Can you make out that the inferior rim is thinner than the superior rim?
Yes, ma'am. There is peripapillary atrophy temporally.
And there's no disc hemorrhage. Okay. So
No
here,
disc
in spite
hemorrhage.
of the rim not looking too bad, you can see the RNFL defect. Okay.
Yes,
So
ma'am.
you have point out the inferior rim. Point out the inferior rim. Or go there and point it out. Show the inferior rim. Inferior. The width.
Inferior rim. So what is the landmark you will use?
Initially, you showed a rim and then you traced it differently when you are looking at the blood vessel, right? So, what is that called? Anyone? That was not the lecture, it was not there though.
I think someone mentioned it
Mentioned
earlier.
it. Okay.
One of the students, I think they can repeat.
Yeah. What do you call? What kind of cupping are you looking at? Yes. So initially he showed was the color cupping. Later on you traced it correctly. That is contour cupping. So you should always look for contour cupping where you trace the blood vessel. That's the correct way of doing it. When you're looking at also, you should only look at the blood vessels, not the color. Yeah.
It's the color photograph of the left optic disc. It's a little large in size. I think the disc is also tilted horizontally. The inferior rim is thinner than the superior rim. A cup disc ratio of 0.7. Yeah, there is nasalization and there is peripapillary atrophy as well. I cannot appreciate a nerve fiber layer defect, and there are no hemorrhages.
This is more like an inferior temporal crescent. Okay, what you're saying there. It's a myopic disc.
Didn't get you, ma'am? What? Yes.
See the difference?
Yeah, it's more well defined, the superior disc margin, as compared to the inferior. So there's an inferior slope. Is that what you're saying?
No. What?
Why is it a tilted disc, sir?
Why? I mean, how many of you would say that it is tilted inferiorly slightly? It's difficult to say that. Could be a slope or it could be some tilt also there. You see, when they are taking the picture, the upper margins are very well defined, like you said, and the lower ones are blurred,
Yes,
right?
Oh, that's
So that means the position of the inferior rim is not at the same plane as the superior one. So there could be a small tilt anterior-posteriorly. So that could be the reason why you are seeing something like this. So you cannot really comment on the inferior rim that much. You can say that it may be looking sloping or tilted. That's all. Okay.
Yes,
It's a difficult disc to comment upon, but the rest of the things you can say.
Yes, sir. How do we tell if a rim is sloping?
Yeah. You described it, no?
Yes. It will be a partial loss of the ring in the area.
Follow the slope of the vessel.
Follow.
If it's not bending, it's going like this you see in the previous one, no? The myopic one. So if you see the vessel inferiorly, it's just going, it's not bending, the smaller one. It's just going straight down, right? The bigger vessel.
Yes,
It's
ma'am.
not bending anywhere. So that will be a slope. If there is a cup and a rim, then it will go follow the contour, go down, then come up and bend at the rim and come out. So follow the contour of the vessel, like the upper or the nasal one. You can see it's going up and then sharply bending at the rim. The
Yes,
nasal one, even part of the inferior temporal, that small vessel. Where
Yes,
the lower ones are just going sloping, like straight. So there's not much of a bend there.
Okay. Yes, thank you, ma'am.
Sharply defined. Okay. So it is the contour is kind of blunted. Okay.
Yes,
so
sir.
like what you are seeing, the blood vessel temporally, you can see there is a bend that signifies there is a defined margin there between the rim and the cup. Same thing with the bigger blood vessel also. But in between, you don't have any blood vessel that defines it clearly. Okay, so that could be a slope.
Like you have a saucer for a cup, and for your coffee glass, you have that other cup underneath, which is sharp. That's an example.
So those kind of things will be very well seen in a stereo photograph. So have a look at some of the stereo photographs from.
There's a stereo atlas. I don't know if it's still there in the library. If it has that
Many of
glass
them have
also,
got that
you can check it
fungal
out.
elements and we
It
threw it off.
has.
So
Oh my God.
it's unfortunate.
Right color fundus photograph of a left left eye, showing a large disc with sloping rims superiorly and inferiorly, with a cup disc ratio of
One minute, is it only sloping?
inferior thinning also.
There's bipolar thinning, no?
Bipolar superior and inferior
rims are
thinning.
thinned.
With a cup disc ratio of 0.8, and there is peripapillary atrophy is present, and there is no RNFLD, or this could be diffuse. There is no RNFLD,
Probably
and
diffuse loss is there.
diffuse loss can be there without any disc hemorrhages.
What else is there? What are the other?
Looping of vessels.
Looping of
Superior
vessels is
looping
there.
of
What else
vessels.
is there?
And lamina dot sign.
Yeah, nasalization, laminar dot sign, bayoneting. Okay. So this is glaucoma.
Yes, ma'am. Now this is a red-free disc, not red-free, sorry. This is a stereo color disc image of the right eye, showing a normal size disc with
Think before you talk. This is not a stereo.
okay, sorry. This is a red disc color image of showing a normal size disc with a healthy NRR, with a healthy NRR showing without any peripapillary atrophy. There is peripapillary atrophy without any RNFLD and without any disc hemorrhages. The vertical cup disc ratio is 0.6. Thank you.